start. We're going to talk about jaundice a little bit. And yeah, as you can see, there was the title of the slide. Throughout the questions, throughout the presentation, I'm going to be asking questions and things. So if people want to just type the answers to the questions I say in chat, or say, I don't know, and things of that nature. And the first question that we have our friend Gollum here asking is, what is jaundice? And Smeagol is helpfully giving you a hint. Just gonna wait a few seconds, see if someone comes up with things in the chat. It's not a trick question. So, well, if you don't know it, it's okay. If you're too lazy to type, that's okay too. I relate to both of those things. Jaundice is, what it says over there. You have too much bilirubin in the blood. It deposits in various parts of the body, specifically in sort of the sclera and the skin, and they become yellower. The reason that the sclera become yellower, I think, is because bilirubin's really good at like depositing in the elastin tissue, sort of in the eyes. So that's why the sclera become particularly yellow. Does anyone know what kind of level of bilirubin you would need to see sort of jaundice? Just give me any number, ballpark figure guesses. 1 bilirubin, 20 bilirubin. 30 bilirubin. 30 bilirubin is fairly accurate. Yeah, 34 to 51 micromoles per liter. And a normal sort of bilirubin level is, am I not seeing your messages or something? No, yeah, cool, I can see them. Yeah, normal level is sort of below 17 micromoles. So yeah, you can have elevated bilirubin and you wouldn't sort of typically see it until it goes over sort of a certain threshold, and then you start seeing it. So yeah, we've established what it is. Now let's talk about what causes it. To talk about bilirubin, we first must know like what lifestyle bilirubin leads. Now there's a lot of information here, and Preena's going to go over more of it again, but really for now we need to be aware of like sort of very basic idea of how bilirubin be. So you have your red blood cells that have a relatively short lifespan, only 120 days. They get broken down into heme and other things. And then the heme is converted into unconjugated bilirubin. Unconjugated bilirubin is fat soluble, not water soluble. And it binds to albumin and travels through the blood into the liver, where the liver converts it into conjugated bilirubin, which is water soluble, and it then makes it easier for it to be excreted. So that's really the main thing that you need to take away from this slide, is the difference between conjugated and unconjugated bilirubin, because different types of different causes of jaundice will cause different types of bilirubinemias, whether it's unconjugated or conjugated, and that will depend on where in this little sort of life cycle of bilirubin that is the problem is. So if it's to the left of the liver, there's going to be lots of unconjugated. If it's to the right of the liver, it's going to be lots of conjugated. So that's sort of a vague idea of that. So to understand, your bilirubin and your jaundice, you have to sort of think like jaundice. You know your enemy, that kind of thing, right? So what I did is I went onto the most reliable site on the internet, WikiHow, and I googled how to jaundice. And there's really sort of 3 ways of making jaundice happen. So you want to increase the amount of bilirubin there is in the body. You can either do that by just having more bilirubin into the body. You can do that by messing with the thing that processes the bilirubin in the liver. Or you can do that by blocking the outflow of the processed bilirubin out of the body. And so you can divide your causes of jaundice into prehepatic, more bilirubin coming in, hepatocellular, or like problems within the liver cells themselves, or post-hepatic, which is problems with the bilirubin flowing out. So we have those over here, where prehepatic is usually, things that lead to excess hemolysis of blood cells. And it's usually unconjugated. Intrahepatic is any sort of problem within the blood cell itself, within the liver cells themselves. And both conjugated and unconjugated bilirubin will be present. And then post-hepatic is a mechanical obstruction, and it's usually going to be conjugated because at that point the bilirubin's already gone through that like little transformation process. And then there's some other sort of signs that you can see with them as well. Like for instance, so itching is typically mostly present with only post-hepatic stuff. But yeah, so once you've got it divided into those categories, it makes it easier to sort of diagnose what the problem is. And for a lot of these things, the treatment's going to be treat the underlying cause. And if you can categorize why the underlying cause is happening, it's going to be easier to see how to, treat it. All right, so I'm going to talk about some of these things one by one. So first of all, we're going to go on to prehepatic causes. And that's really just anything that causes more blood cells to be broken down. And that's something, hemolytic anemia is something that is going to be gone over in a different like presentation probably of its own, because it's a really big thing. Yeah, for now I'm just gonna. Oh, acolic is to do with the lack of bile in the stool. So it's also sort of like less yellowy because there's less bile, which makes sense because it's obstructive. So less of the bile is able to flow out. But that's something that Preena will go over a bit more later. But yeah, so prehepatic causes anything that can cause more breakdown of blood cells. So just as a quick thing, can you guys throw out anything that you think can cause more breakdown of blood cells?
Hint, look at the image.
Yeah, the image is one big clue.
Sickle cell?
Sickle cell anemia, exactly, yeah. Okay, other things.
Dibs on malaria.
Yeah, exactly. Some infections and things as well. What else did someone said? Thalassemia, exactly. Brilliant. Autoimmune causes, exactly. Yeah, so you can split it up into sort of intravascular and extravascular. And so defects within the vessels themselves are like things like hereditary spherocytosis, sickle cell, as you said, thalassemia, someone said, or defect in red cell metabolism, so G6PD or pyruvate kinase deficiency. And then you can also, autoimmune, excellent. Also think about extravascular causes, so either infectious or autoimmune, like in lupus, for instance, or Hodgkin's lymphoma, hypersplenism, lead poisoning can cause breakdown of blood cells, all of these kinds of things. So yeah, this is just to be aware. Like I said, people are going to go over this greater, but in terms of how it causes jaundice, there's lots and lots of bilirubin. The liver can't process all of it, and there's therefore too much unconjugated bilirubin in the blood. So hopefully that makes sense. We're then going to move on to hepatocellular jaundice, which is sort of like lots of different things can cause this. But essentially what's happening is there is a problem within the liver cells themselves, and it's leading to hepatic cell death or disruption of hepatic processes. And then this can cause impairment of bilirubin transport, whether that be bilirubin moving into the cell or processed conjugated bilirubin even moving out of the cell. And the problem can be at any stage, like the moving in, the processing of it, or at the moving out. which means that usually if you have hepatocellular jaundice, there's going to be sort of a mix of both like conjugated and unconjugated bilirubin that's going to be present. But usually excretion is sort of like the rate limiting step, like just the bilirubin moving out of the cell that it's been converted in. And that means that mostly you'll see a predominantly conjugated hyperbilirubinemia. So hopefully that makes sense. And now what we're going to do is we're going to go over some possible causes of hepatocellular jaundice, or generally things that cause liver damage. Hepatitis, liver inflammation. Can people type in or say some causes of hepatitis?
Viruses, alcohol.
Yeah. Exactly. Oh, I thought that one was going to be alcohol, but it came out with ischemic. But there you go, that's a spoiler. So yeah, infectious causes are Hep A, E, B, C, D. Again, a lot of these things are topics in and of themselves, but I'm just sort of going over them. And the more we repeat them, the more sort of like they'll be solidified in your memory. But yeah, A and E typically spread through contaminated food or water. I think they're a little bit more acute as well. And then B, C, D typically spread through infected blood and other bodily fluids. Alcohol we'll talk about in a second. Ischemic hepatitis is just livers not getting enough oxygen causing death of liver cells. And that can be caused by any sort of thing that will stop blood flow, like heart failure or infection or abnormal heart rhythms or hypovolemic shock because of bleeding or a blood clot. Anything of that nature. Then Anusha's favorite cause of hepatitis is going to be autoimmune. There's also another couple of autoimmune conditions associated with the liver. Could someone know what they are? So autoimmune conditions of the liver other than autoimmune hepatitis. Exactly, PBC and PSC. So primary biliary cholangitis, formerly cirrhosis. Auto is an autoimmune disorder where you have destruction of the small bile ducts of the liver. And the big thing that you need to remember about PBC is sort of the 3 M's thing you'll see. The antibodies is antimitochondrial, this smooth muscle antibodies in some patients as well. Raised serum IgM. And I think I didn't put in the M, which is like the maternal thing, but that's fine. Sorry, yeah, so antimitochondrial and IgM. The big thing you need to remember there. Primary sclerosing cholangitis is long-term sort of scarring and fibrosis of the bile ducts. This is very commonly associated with things like UC and has P-ANC antibodies. I think this is one of those things where they say it's autoimmune, but there's like a little bit of debate about it, and it's not doesn't respond that well to like like immunosuppressants and things. But that's a whole other thing. But the main thing that you need to know about these things is like sort of remember the antibodies, and then yeah, as I said, all of these things you'll go over again on their own merits. And with autoimmune hepatitis, this is type 1, which is usually older patients and has anti-smooth muscle antibodies. And there's type 2, which has anti-LKM1 antibodies. Cool. Drugs can cause liver damage. Unsurprising. One of them, alcohol, like hepatitis, and big cause of Western liver disease. And then iatrogenic. Lots of drugs are hepatotoxic because the liver plays such a big role in clearing drugs. And that will include paracetamol, NSAIDs, glucocorticoids, acid, as well as lots and lots of others. I think there's like 900 drugs that have been implicated with some level of hepatotoxicity. So yeah, that's a bunch of different causes of liver damage. And all of those things cause problems with various parts of that cycle of bilirubin being processed, and therefore cause an elevated amount of that in the blood. Hepatocellular carcinoma is another one. So yeah, malignancy in general, but HCC is the most common type of liver cancer. And people with Hep B or Hep C infections, or people with other sort of conditions affecting the liver, like hemochromatosis and alpha-1 antitrypsin, are at higher risk of developing these conditions. Then we're going to talk about a couple of hereditary causes of unconjugated jaundice. And as you can see, I've put like the Wikipedia little image of the UGT1 gene, which I believe is something like uridine, like sulfonide glucuronyl transferase. No, I don't know it. I just looked it up before to scare you guys. You don't need to know like a lot about the gene itself. All you need to know, there is a gene called UGT, and that some people are deficient in it, and it is involved in the process of turning the unconjugated bilirubin into conjugated bilirubin, right? And if you have less of it, you are less good at doing that. And especially in times of stress or other sort of things, what will happen is that the liver won't be able to sort of cope with the load, and you'll have sort of an excess amount of bilirubin in the blood, which can cause some minor jaundice if you have like slightly low level of UGT. This is known as Gilbert syndrome, which usually doesn't require treatment. I think there is a thing if it gets really intense, you can give them like phenobarbital, but most of the time Gilbert doesn't need treatment. It's mostly asymptomatic. It's quite a common condition as well. I think like 5% of the population or something can have it. And it's typically autosomal recessive, although it can also be autosomal dominant. Now there is a more intense form of Gilbert. Does anyone actually know what this is? I'll be impressed if you do, because I did not this time a year ago. Or at the end of last year, for that matter. No, don't worry. That is why we're here, I guess. So, Crigler-Najjar syndrome, as you probably guessed from the slide, if Gilbert is low UGT, Crigler-Najjar is no UGT whatsoever. And this is really, really bad. If they don't get a liver transplant, it will usually be fatal. So yeah, that's hereditary causes of unconjugated jaundice. Right, we're on to post-hepatic jaundice now, which I don't want to talk about, but luckily someone else will, so that's all good. Right, let's move on to the diagnosis of jaundice. So, well, yeah, and in terms of like why it's happening. So when you are looking at trying to figure out why someone has jaundice, what kind of tests and things will you do? What will be involved in your diagnostic procedures? LFTs, yeah, huge one. Because yeah, all I've been talking about for the last 25 minutes is the liver. So knowing how well the liver functioning is pretty big. And then the most, yes, coagulation is really good. Because INR PT is a good marker of liver function. Full blood count, excellent, would definitely do that as well. Also check for things like anemia and other things. But sort of, yeah, albumin, that is kind of part of LFT, but yeah, it's its own thing as well. But the most important thing to remember, always part of any diagnosis, history and examination is going to be like a big part of them. So always just say that, like, yeah, take a full history, do an examination, because that's going to go a long way towards like giving you an idea of where you're going to be looking, what kind of things you're going to be thinking about, what kind of what you're almost expecting to look at in your blood test, like what kind of results you're going to be waiting to see. And then the tests are just usually ways to confirm a lot of the diagnoses that you may already have made based off of those two things if you've done them well, you know, some of the time. But yeah, all things that you guys mentioned, so good jobs. Imaging is more of a thing for obstructive jaundice, so I'm not going to talk about that much, but there you go. So in terms of the history, what kind of risk factors are you concerned about for people for potential liver disease? Very sort of basic stuff to ask about for liver disease. Alcohol, yeah, exactly. Anything else? Travel, yep, 100%. Drug use, absolutely. Vaccinations and infection is a good one as well. Tattoos is another thing linked to sort of like more risk of spreading those kind of things. Their family history is an important thing to talk about, especially for some of like the you know, inherited conditions. Someone mentioned travel previously as well. So yeah, just general sort of risk factors to be aware of. And then in terms of sort of the symptoms that they may have with hyperbilirubinemia, sometimes because of the various causes of it more than anything, abdo pain, fever if they, you know, have an infection and things of that nature, weight loss, pruritus, especially with obstructive, and dark urine or pale stool. Pale stool being the acolic stool that we mentioned earlier because of lack of bile. So cool, moving on to the liver function tests. Test for bilirubin because we're, you know, worried about hyperbilirubinemia. That's fairly straightforward. Tell you how bad it is. Test for the various, like whether it's high, lots of unconjugated or conjugated, because again, that's helpful in qualifying like what kind of cause it's going to be. Right, so in terms of albumin, someone mentioned as well. Yep, really good marker of like sort of liver function. What LFTs are really good at figuring out the amount of like hepatocellular damage. AST and ALT, absolutely, excellent. And there's like a little snippet over there where if the AST is higher than the ALT, that's usually more like sort of alcohol related. But if they're around the same, then viral hepatitis is more of like likely the cause. But yeah, excellent. And then what markers are more related to sort of like biliary obstruction? ALP and GGT were the ones that we were thinking of. I believe that lactate has some involvement, but honestly, I don't know that much about lactate in relation to liver function. But I feel like these are the main ones that you're going to be looking at doing for your liver function tests. But yeah, lactate levels are elevated in cirrhotic patients. I just don't know if that's like one of the first things that you go and do. And I think it's a good marker for how cirrhotic they are. Anyway, don't quote me on anything about lactate. Sorry, guys. These are the important LFTs to be aware of. And then we're going to sort of move on to just general like things to screen for in the liver of like all of the different kind of things that you can do if you're worried about someone's liver, and you'll usually do if like, you know, all of these previous tests, like you weren't really sure what was happening, or you want to confirm your diagnosis and things. So yeah, like all of the infectious causes, like you do viral serology for any of those things, makes a lot of sense. Paracetamol level, as we mentioned before, paracetamol overdose is hepatotoxic. Does anyone know what the treatment for reversing paracetamol overdose is? Yep, exactly. I believe it's something like, or if it's within like a certain time frame, you give NAC, and if it's more than a certain time frame, you give activated charcoal. But I think, as Anush said, this is going to be something that they go over on its own right later. But yeah, ceruloplasmin. Anyone know what that is a test for? If you don't worry. I didn't either. Ceruloplasmin is for Wilson's disease, which is too much copper in or everywhere in the body. ANA antibodies are like typically associated with things like lupus and other autoimmune things. And then for chronic stuff, again, we have ceruloplasmin and anemia. What about TTG? People know what TTG is for? Commonly associated with? Celiac disease, exactly. And alpha-1 antitrypsin, because of the fact that it's on this slide, you can tell that it causes some amount of liver problems. Anyone know what other major body organ does it cause problems with if you have a deficiency of alpha-1 antitrypsin? Lungs is exactly correct, Patrick. Yeah, exactly. And then, yeah, we've talked about some of the autoantibodies before. So yeah, these are just general things that you can think about looking for when you're, especially when you're looking at like sort of medical jaundice. In terms of like surgical jaundice, well, Preena's going to talk about that. So that is, I believe, everything from me. Thank you all for listening. And I'm going to hand over to Preena, who I think is in the process of moving rooms right now.
Yeah, I moved, it's fine.
All good.
Okay, so I'm going to load up my presentation, but if anyone has any questions, just ask them now, and I'm sure Hamza will answer them.
I'm going to take that as a no. That was all very clear. Thank you very much. That's what I'm going to assume.
It's just loading. But I'm also going to make a poll because my first slide is a question. And I don't know if Menti is set up. Can everyone see the slides?
They are visible and the poll is there.
Fab. Okay, so I couldn't be bothered to retype out the question, but like painless jaundice is number 1, pale stools and dark urine is number 2, etc., etc. So everyone just vote. Okay, so we've got 4 votes. Okay, anyone gonna break away from the crowd? How many people are there in total? Has everyone voted, or should I wait? Okay, I'll give it another like 2 minutes for anyone waiting to vote. Okay, feel like everyone's voted. So does anyone want to explain why they picked number 2, like why they picked pale stools and dark urine? You don't have to, but no. Okay. So this was kind of a bit of a mean question to start with, but basically it's one of the type of questions that I used to find really hard last year, which is why I added it in. And it's one where it says like, what's the best indicator for something? Because like all of these could, in theory, be gallstones disease, but unless you like really justify in your head, it's difficult to work out which one the best one is. So the answer was actually E, which is a history of colicky pain. And I'll explain why that is. So does anyone know what painless jaundice is characteristic of? It's not gallstones disease, but it's something else. Good question, Christopher. I'll come to what's colicky pain. So painless jaundice is very characteristic of pancreatic cancer, yeah, when it's at the head of the pancreas. And hopefully by like slide number 5, that will be clear why. Pale stools and dark urine, you're all right, is a sign of obstructive jaundice, and gallstones disease can cause that. But it's really rare that you get like completely pale stools. You often get dark urine, but like you never get 100% pale stools. That's why it's a right answer, but it's not the best answer. Palpable gallbladder is actually the complete opposite of what you'd get. If you get a palpable gallbladder, it's something called Courvoisier's law. That means that like it's not likely to be gallstones. And the reason why that happens is like if you have really long-standing disease in the gallbladder, like stones, there's more and more inflammation, and it means that the wall becomes not distensible, so you can't palpate it basically. Melena would be like if someone was bleeding in their GI tract, and they might do that if they had like liver disease and varices, but then that's liver disease, that's not gallstones disease. And then colicky pain is characteristic of someone having gallstones. So colicky pain is basically pain that comes and goes, and it's usually in the right upper quadrant, but you can have renal colic in either quadrant. So the thing that it's characteristic pain that comes and goes. Often it's after meals, because when you eat, you need bile to digest your fat. So your gallbladder, thank you. So your gallbladder contracts to like release the bile, and that's when the pain comes on. So it's intermittent pain, often triggered by eating. That's colicky pain, and it's not really sharp. It's like a gnawing-y pain. Often people are like, it's just there. Sometimes it's dull, but that when they say that, that means they've got colicky pain. Hopefully that's clarified your question. Okay, so we're going to talk about obstructive jaundice today. There might be some overlap with what Hamza said, which is great, but I'll try and explain things in a slightly different way. So firstly, just like bile and bilirubin, and just to recap, bile is made up of 2 things. It's made up of conjugated bilirubin and your bile acids. So your bilirubin, it is made from it's a breakdown product of heme, and when it's like initially made, it's not conjugated, it's not soluble, it's just kind of there in your plasma, and it gets bound to albumin, and that's what brings it to the liver. And then in the liver, it gets conjugated, it becomes soluble, and then you excrete it through your bile. And that is it's just a waste product. It has no function whatsoever. Bile acids, on the other hand, are made in your liver from cholesterol, and they help with absorbing fat. And together, bile acids and bilirubin make your bile. And I'm sure you guys remember, but your bile is stored in your gallbladder. Okay, so what happens to your bile once it gets released into your gut? Does anyone know? What does it get converted to? Okay, I'm just going to tell you. So in the colon, it gets broken down by bacteria into these two things. They're not like, you never get asked in SBA what does they get broken, or you never need to spot that in SBA. But once you get this, once this clicks, all of jaundice makes sense to me, or all of obstructive jaundice makes sense. So I'm going to try and like explain my thought process to you guys. So urobilinogen, the way I remember it is like that's urine, that is absorbed back from the colon into your blood and it gets excreted into your kidneys. Stercobilin is it's like stool, and that's like a brownie colored, I'm going to say molecule, I don't know what it is to be honest, but it's like a brownie colored thing, and that is what makes your stool brown. So obviously if you don't have either of those two, the process of like clear urine and brown stools won't happen. I feel like you can kind of see where I'm going with this. And obstructive jaundice is anything that will obstruct the flow of bile from your gallbladder out into the duodenum. This is your biliary tree. Bile will like get produced in the liver or like stored in the gallbladder, and it will come out of here and into your duodenum, and that entire process I just told you about will happen. So what happens if something obstructs it? The first thing that happens is you don't get any bile going to your duodenum, so you don't get any stercobilin. So does anyone want to guess what the clinical manifestation of that is? Clinically, what would the person complain of? Not quite constipation. So if you don't have any, so what does stercobilin do? It's the brown colored liquid that makes your stools dark. So if you don't have any of that, what are they going to say their stools look? Yeah, exactly. You get pale stools. Good. So you get, oh, go away. Sorry, my computer is just having a bit of a moment. Okay, so your bile backs up. The clinical manifestation is pale stools. The next thing that happens is if you don't have any bile going through this tube, basically flowing out, it's going to back up behind the obstruction. So where's it going to go? Where can it go? Can it go back into the gallbladder? Someone guess. No, I mean, it might not. I don't actually know. Probably it can, and then the gallbladder gets full, and then it can't. Can it go back into the liver? Yeah, exactly. So it goes into your bloodstream, and the way you remember that is because this is post-hepatic. It's after it's been conjugated. So your conjugated bilirubin can be reabsorbed. It's soluble. It doesn't need albumin anymore. So it gets reabsorbed into your bloodstream to the surrounding tissues, and it goes to your kidneys. So I've just answered that question for you. It's conjugated biosoluble. But in the kidneys, what's the clinical manifestation of having conjugated bilirubin coming out in your urine? I don't know if that's intentional, but dark urine, exactly, yeah. So that's why in obstructive jaundice, you get dark urine and pale stools. And hopefully that's clarified the like physiology behind it. And in the corner, I've put this photo up because in my head, I used to think that like bilirubinemia or bilirubinemia, having bilirubin in your urine is like dark stool, like black, kind of like a Guinness. But actually, it looks a bit more like this. So sometimes people might say, oh, I've got bloody wee, or like it reddish or dark red. So always have a look at the urine yourself as well if you can. Okay, before we move on to the causes, I just want to put a disclaimer out there that sometimes someone can say they've got pale stool And there's one other really big differential that you need in the back of your head when someone says pale stools. Does anyone know what that is? So the main differential is steatorrhea, like fatty stools. So when people have pale stools because of obstructive jaundice, they don't have steatorrhea. Like both steatorrhea and pale stools are pale, but steatorrhea is really hard to flush and it stinks. And that's not what happens to people with obstructive jaundice, because they can still absorb their fat. They've still got other mechanisms of fat absorption. It's just the color that changes. So if someone in a history like says to you, my stool is pale, double check that they've got like, that it smells okay and that it flushes okay, basically. Okay, so moving on to the causes of obstructive jaundice. If you haven't realized with like Anusha's teaching, we all like classifying things. We all love a system. So does anyone have any any ways you can classify the causes of obstructive jaundice?
Systems are the best ways of remembering things.
Absolutely.
Just memorizing.
Where it is, yeah. So Jordan's kind of got the hit the nail on the head there. You basically classify it by location, but not just gallstone, by pathology, because there's other things other than gallstones that can cause obstructive jaundice. So this is the way that I think about it. It's your biliary tree is just a tube, and something in the wall of the tube, so, or like inside the tube in the like hole, luminal basically, can obstruct it. Something in the wall of the tube can affect it, so that's mural, and then something can just compress it shut from the outside, and that's extramural. So we'll start with luminal. Does anyone know any causes of obstructive jaundice that might be like inside the tube and block flow? There's the really obvious one. Okay, so gallstones is the main cause of or like the main thing that you could get inside that would block a tube. You can also get ascending cholangitis. Does anyone know what ascending cholangitis is? So I'll try and break it down. What does itis mean at the end of a word if there's itis? Infection, yeah. Infection or inflammation, exactly. So ascending cholangitis is when you have an infection above the gallstone and it starts tracking up and you get worried because you don't want it to get to the liver or the gallbladder. And when you do enough PassMed, you'll realize that PassMed loves a triad for ascending cholangitis. Does anyone know what it's called? Okay, I guess we'll do it the other way around. Can anyone think what might be in that triad? If you have 3 clinical signs for someone who might have an infection of their gallstone area, what could it be? Fever, yep. Pain, yep. And jaundice, exactly, yeah. So fever, right upper quadrant pain, that's Charcot's triad, exactly. So that's that basically, if you read that, they've got ascending cholangitis in an SBA. And then finally, the other luminal cause is called congenital biliary atresia. I've never seen it or heard of it or know anything other than what it is about it, but I put it there for completeness. So it's basically when like people are born with like no lumen in their biliary tree. It's like a closed pipe from day one. So they have like neonatal jaundice. Okay. Oh no, I gave that away. maybe you didn't see it. Does anyone know like what could be a pathology affecting like the wall that causes obstructive jaundice? Any guesses?
Also, it's worth pointing out that if you're struggling with any of these like causes, you can always fall back on vitamin D, like the surgical serum. We just haven't gone through it because it's quite time consuming. But like immunoscopy, if you're running out of answers, always fall back on that. On
the surgical sieve, yeah. Okay, so I'll show you the causes I had. So yeah, so they've got cholangiocarcinoma. So this is a tumor of the wall of your biliary tree. PBC and PSC, Hamza touched on briefly, but they're basically conditions that affect either your biliary tree or your liver. So they cause like sclerosis, and I'm really struggling to remember much more about them, to be honest.
You basically get strictures, which cause blockage. You get inflammatory strictures. That's all you need to know.
They cause the wall to narrow, basically, and then you get drug-induced liver injury in the liver. So this is one of those odd ones where the pathology is actually in the liver, but it's not affecting conjugation. It's not intrahepatic. You can still conjugate fine, but it's the fact that you've got liver injury and so much like hepatitis that the walls are just like not shut, but like squished together because of all the like fibrosis, basically. Does anyone know any common drugs? I think Hamza mentioned it, or Mark put it in the chat. So let's see how we're holding up from 20 minutes ago. Any common drugs that cause drug-induced liver injury? Probably, yep. Not the first two I'd go for, but yep. Sure. They're still not the first two I'd go for, but they're all really good answers. So the two that I have in my head are paracetamol and amoxicillin. They're or Augmentin, which is Coamoxiclav, I think. But they're the two that I was always told about. If you've been told about methotrexate, rifampicin, isoniazid, learn that. Okay, finally moving on. Extramural causes, so anything from the outside that's compressing the biliary tree. I've already spoken about one on slide number 1, but anyone want to tell me about what could be an extramural cause? Pancreatic cancer, yeah, good. Anything else? Nope. Okay, don't worry. So the ones I have are head of pancreas cancer, pancreatitis, lymph nodes near like the biliary tree and the portal vein, which then get bigger for many reasons, and then Miritzi syndrome. So let's start with head of pancreas cancer. That's when you have a cancer at the head of the pancreas. So if I go back a few slides, in your biliary tree, you get you have your cystic duct that joins to form your common bile duct, and your common bile duct for a little while runs through your pancreas, and then it opens out into the sphincter. So there is a part of the biliary tree inside the pancreas in the head, and obviously if there's a massive cancer growing, that's going to get compressed. Does anyone know what the cardinal feature is for head of pancreas cancer? I mentioned it earlier. Painless jaundice, yeah, because they've got a cancer that's growing and they don't know it, and then one day they're jaundiced. So it like pain. If you read painless jaundice in a question, that's head of pancreas cancer. If you obviously like see someone and you're clerking them and they've got they're jaundiced, but like maybe their colicky pain is as clear or hasn't got as much of a defined history, then you can ask about other things. So what other questions could you maybe ask, or like what other signs could you look for in someone who might have cancer? Unexplained weight loss. Yeah, exactly. Good. So unexplained weight loss and painless jaundice is pancreatic cancer until proven otherwise. Pancreatitis, you can also get obstructive jaundice, but I'm going to put a bit of a disclaimer out there about pancreatitis. Someone doesn't get pancreatitis and then they're jaundiced. Like, the reason why there's an association between pancreatitis and jaundice is because the most common cause of pancreatitis is a gallstone. So sometimes they've got gallstones disease and jaundice, and then very close in their timescale, that gallstone causes pancreatitis. So it wouldn't, pancreatitis isn't always my top differential when you think jaundice, but know that there is an association there. Does anyone know of any eponymous signs that you can get if someone has pancreatitis? No? Okay, so they're called, I think it's Cullens and Gray Turners, but that is also off the top of my head. So just put that in a search in PassMed and it will come up.
So those are specifically hemorrhagic pancreatitis?
Yeah, so when you have pancreatitis and there's loads of bleeding, you can get like purple discoloration either in your flanks or like around the umbilicus, and they have those eponymous names. Yeah, exactly. Marucci syndrome, very finally, very quickly. You don't need to know much about it, but like everyone kind of gets obsessed with it, thinking it's one of those like top decile things. So I'm just going to talk about it quickly. But what happens is there's a gallstone. It's actually sitting in your gallbladder, and it's so big, and like the anatomy kind of like your gallbladder is right next to your common bile duct. So through the gallbladder, it compresses your common bile duct. So it's not in your common bile duct, it's in your gallbladder. It's extramural compression from the outside. It's just, it happens purely based on like where the stone's sitting and your anatomy. Okay, that's all Marucci syndrome is. And in your feedback, some of you put that you wanted to like kind of like know what to focus your reading on. So anything on bold in this slide, I would say learn. And I mean learn cause, diagnosis, management, treatment. Anything in italics, have like an awareness of. So like know that cholangiocarcinoma is a cancer of the wall, and like learn some drugs that cause liver injury, but don't go crazy with it. And then anything that's just in normal font, I never learned in too much detail. I just knew that they existed. So if you're struggling or want to know where to start, go with that. Okay, so we're going to finish on a case.
I was just going to say, from an OSCE perspective, if you presented your differential for jaundice like this, they're going to hear the words transmural, luminal, and extramural, and they're going to stop listening and give you full marks for that section. Like straight up, that's what's going to happen. So if you can structure your exam in OSCE, you're going to do really, really well. So like, if you try and like present it like this when you're learning it yourself as well.
Okay, so we're going to do a case. You've got, can someone make another poll while I read it out? You've got a 42-year-old patient. She reports constant itchiness all over and is visibly jaundiced. And her past medical history is that she had gastric banding for obesity 2 out of 12 ago. So does anyone know what that means, 2 out of 12? Two months ago, yeah. So I don't know if you've had like a clinical documentation session, but basically if you ever read like a fraction like that, the bottom number is like months or weeks. So if it's out of 7, it's days. If it's out of 52, it's weeks. If it's out of 12, it's months. And then the number on top is how many. So 2 out of 12 is 2 months ago. If it was like 6 out of 52. That's 6 weeks ago. So if you see that in some notes, that's a helpful tip for the ward. So yeah, she had a gastric banding for her obesity 2 months ago, and she's got type 2 diabetes. She takes the combined oral contraceptive pill, that's COCP, and she has a family history of diabetes. Which of the following is not a risk factor for her gallstones disease? I'll set up a poll, actually, don't worry. How do I do it? I've completely forgotten. If anyone feels brave and just wants to like go for it, go for it. I'm just setting it up.
Yeah. I think it's probably fine. Like you start at home, just write down a piece of paper, the answer on a piece of paper in front of you, and commit to something. You don't need to share it with us. It's more for your own learning than like we don't really mind. And then if anyone wants to maybe volunteer why they think one of the answers is correct, then we can talk through it. Like, yeah, we try and set up polls. It's just I think we've all had pretty hectic weeks, so sorry.
That's fine. And if you don't like this question, take comfort in the fact that you're never going to get a negative question in the SBA. It will never ask you which one of these is not the answer. But I figured I could embark more risk factors on you this way. Okay, hopefully you've all written down an answer. But I'm going to just show you the answer. So the answer is oral contraceptive. That's not a risk factor for gallstones disease. So let's go through this bit by bit. She's itchy and she's visibly jaundiced. So she has, when you get jaundiced, itchiness is a common presenting complaint. That's all I wanted to highlight with that. And she had gastric banding for obesity, type 2 diabetes, and a family history of diabetes. All of those are risk factors for gallstones. And the way you can remember it is literally like how they relate to the pathophysiology. So if we go back, bile, gallstones are basically, if you get enough saturation of your bile, it will crystallize. And your bile is made up of your bile acids and your bilirubin. And your bile acids, if we remember, they're made from cholesterol. So anything that ups your cholesterol, obesity, diabetes, metabolic syndrome, all of that predisposes you to gallstones. Bariatric surgery or rapid weight loss also does that, but the reason it does that is because you go from a state of having high cholesterol secretion to not a high cholesterol secretion, and your like proportions go off. So you aren't taking in as much fat and you're not eating as much, so you don't need as many bile acids after a meal, but the cholesterol is still there. It takes a lot longer for the cholesterol to get cleared. So then suddenly the like proportion of cholesterol to bile acid in your bile has tipped, and it becomes more saturated. Does that make sense? Someone just put yes or no. I really want you guys to understand that, because once you do, you don't actually have to remember this long list. You just have to you can just work it back out. Yeah, good. Okay, important drugs are estrogens, but not the combined oral contraceptive. It's just the hormone one. I had this in my notes, and it says this on BMJ as well, but I couldn't actually work out why. So, if anyone wants to ask a consultant and find out, that'd be great. And the other,
I wouldn't worry too much, because it's more a year 5 topic as well.
Yeah. And the other risk factor is Crohn's. So in Crohn's, what part of the bowel is mainly affected? Does anyone remember? Small bowel or large bowel?
We'll cover IBD at some point as well.
Well, okay. So it is the small bowel. It's your like terminal ileum. And basically that's where your bile acids are recycled and reabsorbed. So in Crohn's, the same thing happens. Your imbalance gets tipped, but it's not because you've got more cholesterol. It's because you're just like not reabsorbing as many bile acids. You're just losing them. Okay, so She has been experiencing some right upper quadrant pain after meals. It all sounds very colicky. We're worried about gallstones, so we do some like OBS and blood tests. So here are her observations. She's temperature's 38.1, heart rate's 102, blood pressure's that, respirate's 19. So without even looking at the blood pressure with blood tests yet, what about her OBS is concerning you? I specifically haven't given you normal ranges for her OBS. Is there anything abnormal in her OBS? Okay, so let's work down the list. Temperature, normal, high, or low? Yeah, so she's slightly tachycardic. I'd say 100 is where I'd start thinking she's tachycardic. So yeah, she's got high heart rate, but her respirate is on the higher side as well. And her temperature's high. Yeah. Okay, so let's look at her bloods now. What's abnormal? Just type them out. Yeah. Pretty much everything is kind of all over the place. Sad times. Okay, so let's see if we can work out some like logic from this. So her amylase is normal. She's not got pancreatitis. She sounds history-wise like she's got some gallstones. So you'd expect her liver function to be deranged. Like you'd expect her to have obstructive LFTs, so her gamma GT, her ALP, you'd expect both of those to be raised, and so that's not surprising. Her ALT is like slightly high, and sometimes it's never a perfect picture. Like sometimes your ALT and AST are affected in obstructive jaundice, and sometimes the converse is true. Your ALP and gamma GT are affected in liver pathologies. So I wouldn't put too much significance on the ALT. I just put it there to be realistic. Bilirubin's high, we know that she's jaundiced. So nothing in her liver function is new, like that, or new news. But what is new? She's got some raised white cells, her CRP is really high, and her temperature is really high. So what are we worried about? Infection, exactly. And not just infection, but what's the extreme if someone has an infection? Sepsis. Always think about sepsis. Yeah, good. So, and her source of sepsis would be probably what I said earlier, which is an infection above your gallstone, also known as ascending cholangitis. And now, if we look back, she's got fever, right upper quadrant pain, and jaundice. She had Charcot's triad as well. So this case was someone who had ascending cholangitis. So my next question, and I'm not moving on from this next slide until someone types out an answer. What are you going to do now that she's septic?
Harsh but important.
Sepsis 6, yes. Okay, what are the sepsis? Well, yeah, exactly. So you do A to E, sepsis 6, give 3, take 3. What do you give? What are the 3 things you give? Yeah, this is pretty much the last slide. Okay, so you give antibiotics, you give some fluids, and you give some oxygen. Yep. What do you take? I've kind of given you the answer. So you take some lactate, you take some blood cultures, and you catheterize her and start taking a fluid balance. Okay. So this is just a recap of some of the like big words you might see. Biliary colic is when you have a gallstone in the gallbladder and it causes that colicky pain we spoke about earlier. Ascending cholangitis is infection above that stone and it starts tracking up and you get Charcot's triad. And it's, to clarify, an infection, so you do need to give these people antibiotics. Acute cholecystitis is when it's just obstructing the cystic duct and that leads to inflammation. But they don't have an infection, they don't need any antibiotics. And then cholelocholithiasis is basically the posh word for obstruction in the common bile duct, not the cystic duct, because that's cholecystitis, but the common bile duct, and you just get obstructive jaundice. So what Jordan said earlier is this is the other way that people classify gallstones disease based on the location of the stone. So if it's in the gallbladder, you get biliary colic. It moves down into the cystic duct, you might get some cholecystitis. It moves even further down into the common bile duct, you get cholelocholithiasis. Everyone be proud I pronounced that. And at any point, if it gets infected, you've got cholangitis. Okay, thanks for listening. Does anyone have any questions?
Also, as usual, I'm going to plug for feedback.
Yes.
Because it's super useful. Like you saw, like some of the stuff Preena changed in terms of like based on your previous feedback. Also,
Yeah.
like, this week would be especially useful because Hamza, correct me if I'm wrong, but you haven't done any teaching before. This is like your first experience of teaching.
My first experience of medical teaching, but yes.
Yeah. So I think I would be correct in assuming he would be very appreciative if he knows like what went well and what didn't go so well when he does some more in the future. So let us know.
Also, the feedback isn't just like how did we do, but there's like a little question there, like what else do you want? So if there's like a list of topics that you want, just put them on there, because that's how we got the idea for jaundice. Like someone wanted us to cover this.
And we've been talking, haven't we, about like what we're doing for the next couple of weeks, and that's all come from that list as well.
Yeah.
Yeah, let us know. Also, if you have any questions,
Yeah, generally, if you have any questions, you can just ask, put in there, send us a message. But yeah, key points: dark urine, pale stool. Always think about sepsis, and have a system. It's a big topic, but you can do it. I did it.
If you can understand jaundice, you can understand any topic in fourth year. I think it's genuinely one of the most challenging topics in fourth year.
It's also really feel good because if you can understand it, you've ticked off like 6 things on your curriculum map. Like,
yeah,
I get so much satisfaction from ticking 6 boxes.
In the last 3 weeks, I think we've covered like a few of the really big topics. So like if you can understand that, you're already doing really well in terms of how you're approaching the year. Right, I'm going to stop the recording there before I forget.